Welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for May 29th, 2019. Our presenter today is Dr. Amanda Nelson, who's an assistant professor in the UNC Thurston Arthritis Research Center and co-principal investigator for the Johnston County Osteoarthritis Project. As a rheumatologist, she understands both the challenges and best strategies for managing OA from her experience working directly with patients, both in clinical care and in research. She is also the first rheumatologist in the country to lead a Walk with a Doc chapter. Welcome, Dr. Nelson.
Thanks, Allison. It's great to be doing another Lunch and Learn. I did one many years ago as a fellow and haven't done one since, so I'm excited to do this. I have the opportunity to summarize for you a 25 years worth of work in the Johnston County Osteoarthritis Project today, so I'm going to talk fairly quickly and try to keep up with myself. This map is here for anyone who's maybe not from the South or not familiar with North Carolina. So Chapel Hill is up here, Raleigh is there in orange, and Johnston County is just to the southeast of Raleigh. It's partly rural and partly urban. And the original JoCo project focused on the 6 townships that are marked with stars. And for the first, I've used this slide many times, and I just noticed that it says that South Carolina is to the south of North Carolina. So, there you go. Johnston County was first envisioned and started by Dr. Joanne Jordan, pictured here, who was the original PI and PI for 25 years of this really impressive study that she started. In 2017, myself and Dr. Yvonne Golightly took over the project as co-PIs. We have benefited for many years from a very stable local staff who have a lot of community ties and are really invested in the success of the project and retaining participants and making sure everyone's happy and making sure they phone call and do open houses and all kinds of things. And they're really the backbone of the whole project. So for anyone who doesn't know, the Johnston County Osteoarthritis Project is a prospective population-based cohort study that's really important. I'll come back to that several times. It initially enrolled all non-institutionalized adults from those 6 townships who were 45 years and older. They were African American and white men and women, and we oversampled African Americans to make sure that we were able to include them in analyses. As I mentioned, it started in 1990. Over the years, it has involved more than 4,000 unique participants, and again, has been ongoing for more than 25 years. We've had follow-up about every 5 to 6 years. It fluctuates a little bit for a variety of reasons, but there's kind of a rough timeline below here showing baseline, first follow-up. We had an enrichment cohort that came in to replace some of our losses, and then we followed people over time. Everyone who participates in the Johnston County Osteoarthritis Project undergoes a variety of different examinations and questionnaires. They give us a lot of self-reported data. This is about their general health, comorbidities, function, pain, psychosocial issues, a variety of different things that might impact their lives. They undergo a physical examination by our trained staff. They have radiographs of multiple joint sites. Everyone has had hips and knees, and on later follow-ups, we've had hands and spine, feet and ankles. We collect blood and urine samples, and at a few time points we collected toenails. That was for metal assessments and environmental exposures. And they also do performance-based functional assessments. So it's a really wide-ranging study. And I should mention at this point that there are references at the bottom of all the slides that are papers that are relevant to that content. And at the end, I have a reference list to just kind of cover the breadth of the study. So in general, participants are from 45 to over 90. They have a mean BMI around 30, so they're generally obese. There's about a third men and about a third are African American. And it's a unique study, so it's population-based. The importance of that really is in generalizability. So these individuals are not selected based on OA or symptoms or pain or seeking care or anything like that. They're really selected by household to represent the county as a whole, and therefore are generalizable, at least to the southeast, if not to the full United States, depending on what the purpose of the analysis is. The study is diverse, so while many cohort studies are primarily white and often primarily women for this kind of disease, we have those categories, but we also have socioeconomically diverse participants from a variety of occupations and backgrounds. We have rural and urban. We have African American and white, and a variety of other things that really make it much more representative of the population at large. We have data for environmental exposures, which I mentioned earlier, which is a unique aspect. We have more than 25 years of follow-up, which is by itself pretty remarkable. And we are currently enrolling a new cohort, which I will talk more about later. We've included multiple joint symptoms and radiographs over many time points. So this is not a knee-focused study. It's really a whole body burden of OA study, in addition to other chronic diseases. And these people are well characterized for a variety of other features. So you can study non-OA conditions or just pain or medications or other things that you'll get an idea from the rest of the talk about. So first, kind of our bread and butter, just providing these generalizable prevalence estimates because of the population-based nature of the study. So we were able to provide these for both the knee and the hip. So here you see for knee osteoarthritis, the prevalence of symptoms at the knee. So this is pain, aching, or stiffness by race. Radiographic knee osteoarthritis, defined by the Kelvin-Lawrence grade, and symptomatic, which is a combination of both symptoms and radiographic OA. And you see that these are slightly more common among African Americans at the knee, and very similar at the hip. Although prior literature had really suggested that African ancestry individuals, such as islanders or African people, were much less likely to have hip OA, we found that African Americans are actually very similar in their frequency of hip osteoarthritis to white participants. Similarly, we can look at incident disease. So the last one was just prevalent, the existence of disease in the population. Incidence is development of new disease because we have this longitudinal cohort. So we can watch over time as people develop symptoms and look by race, as they develop new radiographic osteoarthritis or develop symptomatic OA. And these are incidence rates per 1,000 person years. And similarly for hip, although hip is overall less frequent in the population. And again, the references have all the details down below. We looked at lifetime risk. So sometimes it's not that useful to know person years and some of these sort of cumulative numbers. But if we can just say by the age of 85, most people in the United States are at an average risk of about 40% to develop hand osteoarthritis. Well, that's a meaningful number. It was higher for women, higher for whites, as those who are clinicians will recognize. The lifetime risk of hip osteoarthritis was slightly lower at 25%, and there were no differences by those demographic factors that we kind of talked about. And it was 45% for knee osteoarthritis, and that was higher among those who were obese or who had prior injury, which also makes sense. We found a lot of racial differences, primarily in radiographic OA. I'll show you some more of this later. At the knee, African Americans were 2 to 3 times more likely to have osteophytes or bone spurs and tricompartmental involvement, which means medial and lateral tibiofemoral joint and patellofemoral joint. So they had a lot of osteophytes and they had more involvement of the whole knee compared to the white participants that were otherwise similar. At the hip, African Americans had 2 to 3 times were more likely to have superior joint space narrowing, which is a pattern that has been shown to lead to joint replacement. They were also twice as likely to have osteophytes, again, on both sides of the joint, so just greater burden of those bone spurs. Also at the hip, African Americans were less likely to progress, to have worsening radiographic OA, but they had worsening range of motion and poorer disability outcomes than did white participants. As I mentioned, we've looked at multiple joint osteoarthritis, both radiographic, which is shown here, and symptomatic. It has a very similar pattern. And this chart is just showing you a variety of different combinations of joint sites that were involved. And we see that for those that include the hand, those are much less common among African Americans, meaning that African Americans were less likely to be affected by hand osteoarthritis, either alone or in combination. And if we compare that to large joint phenotypes, so people with hip and spine, hip, knee and spine together, so multiple large joint involvement was more common among African Americans. We very recently completed a systematic review of definitions of multiple joint osteoarthritis. So this is something that's often called generalized OA. It turns out that that term doesn't really mean anything. There's no consensus definition of what that is. And we actually found 10 definitions of multiple joint osteoarthritis, which are listed here, across the literature that had a variety of studies to support them, which are listed here in the references. And we looked at each of those definitions and their frequency for both radiographic if we defined it radiographically, or symptomatically within the Johnston County Osteoarthritis Project. And you can see they vary widely from 2% for the bilateral knees and spine up to nearly 75% here for sort of multiple hand joints. So that's of interest to know that that definition is really so poorly defined in nature. But we also found that almost all of the definitions had a negative impact on general health and physical function. So no matter which one you met, it was worse to have OA in multiple joints than it was not to meet any of those definitions. My co-PI, Dr. JoCo, who I mentioned earlier, has had an R01 about joint hypermobility. So again, trying to think about novel risk factors, ways we might impact osteoarthritis. And she looked not only at JoCo, but at some other longitudinal and cross-sectional cohorts that we have available in our center. And I just summarized some of this. There are many citations there that you can look at. But essentially, in cross-sectional analyses, hypermobility was not associated with a variety of OA outcomes. It was associated with ankle and foot radiographic OA and pain, which are not usually assessed and is really something that we're interested in. Being hypermobile at the trunk, which is this maneuver shown here, was inversely associated with back pain and spine OA. And there were no real significant positive associations with multi-joint OA. One was actually inverse, meaning there was less multi-joint OA in people that had hypermobility. I've been particularly interested in various aspects of joint shape. So femoroacetabular impingement syndrome is a problem at the hip that I'll show you in a minute. This is a consensus definition that came out actually after I started working in this area. But the idea is that people have symptoms in their hip or their groin. They have impingement signs that have to do with limited range of motion in the hip. And they have a variety of specific radiographic features. And the interest we had using the Johnston County data was to look at the population-based prevalence of those features. So how common is it to have radiographic features that would be consistent with the femoroacetabular impingement morphology? And so this paper, which was first authored by a fellow here, looked at the population-based prevalence of several of these features in more than 5,000 hips, which again is the strength of this study in the large sample size. And we found that cam impingement, which is essentially this little bump that sticks out of the femoral head and can impinge when you go through full range of motion at the hip, was in about a quarter of men and about a tenth of women, which is fairly consistent with prior estimates. About a third of the radiographs had evidence of mild dysplasia, which is the acetabulum not fully covering the femoral head, and pincer deformity, which is overcoverage by the acetabulum over the femoral head, was seen in about 1 in 15 men and 1 in 10 women. And so these are estimates that we were able to provide uniquely to this cohort. We also looked at racial differences and things that I don't really have time to go into. We did a case control study as well that looked at people that went on to develop radiographic hip osteoarthritis versus people that did not, and found that cam morphology, again, that bump at the femoral head, was more common in those that went on to develop radiographic hip OA. And protrusio, which is kind of a deep socket, a deep acetabulum, was more common in women that went on to develop hip OA. Through that work, I really became very interested in more global ways to assess joint shape. So everything I just showed you was sort of angles and measures and drawing circles and using kind of basic geometric tools. But there are ways to do more statistical shape modeling, which is what is kind of shown here, that get at sort of the overall shape of what that proximal femur looks like and how it might then interact with the acetabulum. Same thing at the knee. We've developed collaborations with people around the world to look at joint shape and have some more ongoing because of our longitudinal study and all of these radiographs that we have available and all of the other clinical information that goes with them. So this is an example of the ankle. Ankle is really understudied in osteoarthritis, similarly with foot. And we first just did a cross-sectional study, say how frequent is this? Well, it was in about 7% of the Johnston County cohort. And this is at one of the follow-ups where we collected ankle and foot x-rays. And we then went on to look at one of these shape models. So the points are shown here, and then one of the resultant models is shown here with the mean shape and plus and minus 2 standard deviations. And we're able to see differences in people that had had a prior injury versus those who had not had a prior injury. There were also modes that were different by race, which is very interesting. We can use ultrasound. So I got a Rheumatology Research Foundation grant a couple of years ago to allow us to do ultrasound of the knee in the Johnston County 4th time point follow-up. We have our longstanding radiology technician, Sue Guin, who has been now trained to do ultrasound. She also does all of our standardized x-rays. We have 4 expert readers who are rheumatologists, and we've been able to assess feasibility and reliability. That was reported at the Osteoarthritis Research Society meeting last month. And we are currently preparing an abstract for ACR this fall, looking at association between ultrasound, x-ray, and pain. Ultrasound is nice because it's a little more sensitive than x-ray. You can see a lot more stuff, but it's more accessible and more acceptable to patients than is MRI. So here we can see the kneecap, the quadriceps tendon, the femur along the bottom. If there were fluid in this joint, it would be here. On this side is a cross-section with the femur coming across here, and this is normal cartilage laying here. A lot of times we'll see cartilage thinning or osteophytes or fluid in here. So it's a really very useful technique. Dr. Callahan and Dr. Cleveland have had an R01 to look at mortality. So I mentioned earlier that this has been going on for 25 years, and we started at age 45. So a fair number of participants have died over those many years, given that some of them came in at age 90. And so that has provided sort of another avenue to look at. And I just included a couple things from this very recently published paper. This is a Kaplan-Meier curve looking at survival in years over the 25-year follow-up. And in blue are people that don't have radiographic knee OA or knee symptoms. In green, people that have radiographic knee OA only. In blue, people that have knee symptoms only. And then it's kind of the, in red. And then this darker brownish line at the bottom is people that have both radiographic and symptomatic knee OA. And you can see a decrement in survival based on status there. And if we then look at the models, which are adjusted for a lot of different things that might affect mortality, we can see that knee pain, with or without radiographic evidence of osteoarthritis, is associated with about a 20% increase in all-cause mortality, and similarly, maybe even a little bit more for cardiovascular disease-specific mortality. And another paper on the hip is under revision at this point. Then, we don't have to look at osteoarthritis at all. So we have a large cohort of longitudinal data on aging population. And so this was a student working with Dr. Golightly who wanted to look at polypharmacy and incident frailty, which is something we probably wouldn't have envisioned, several years ago, but is something that's really important now. And she found that about 41% of the cohort had been exposed to polypharmacy, and 21% excessive polypharmacy, which was defined as more than 10 medicines. Incident frailty, so the development of frailty over time, was about 15% over 5 years. And you can see that the ratios here for medication count and frailty are 2 to 2.3. So people are more likely to become frail if they're having polypharmacy, which might be a modifiable risk factor. So maybe we can go back, look through those medication lists and reduce that pharmacy burden. So she presented this in Prague, and then the manuscript is now under review at JAGS. So I've given you a very broad overview of what we've done, but I also want to mention that there's a lot of other data there, and I can't show you all the papers. So we have information about biomarkers in osteoarthritis, lead and selenium, which I mentioned a little bit earlier. So other environmental exposures might be modifiable risk factors or reasons that people progress OA, dietary and nutritional factors. We've looked at bone mineral density and body composition and how those might impact osteoarthritis. Dr. Callahan's been very interested in socioeconomic status, neighborhood characteristics. We've had a couple of colleagues work on pain thresholds and centralized pain and how that's important in osteoarthritis. We've looked at falls and functional status. I mentioned frailty. We're very interested in physical activity, obviously, as a way to reduce pain in osteoarthritis and potentially be a preventative strategy. And we focused a lot recently on multiple chronic conditions because that's really an interest of the medical field as a whole. And we have this large population-based cohort that we can go back and look at questionnaires about various health conditions, medications, etc. So I mentioned briefly at the beginning that we're enrolling a new cohort, and then I showed you mortality data from the original cohort. So as we follow those people and they have natural attrition, we have now begun to enroll a new cohort using this really remarkable infrastructure that's been built over many years to sort of see how things have changed. And so we can look at again, population-based, but now including younger individuals. So we know that osteoarthritis is affecting people earlier, and so we start now at 35 years of age. We know that the demographics of the county and the country are changing, and so there are more Hispanic residents of Johnston County that really were not there 25 years ago, and so we're going to include Hispanics, and we're going to oversample again, both for Hispanic and for African American participants. This, again, will be the strict population-based sampling strategy, so it will be generalizable to the population. It will provide information beyond just this cohort and rather more toward the entire United States. And as always, we welcome collaborations. Much of what I've shown you is collaborations with a variety of different investigators at different groups, and that's really the part that makes all of this really fun. I want to be sure to acknowledge our funding sources. So the Johnston County Project has been funded since its inception by the Centers for Disease Control and Prevention, and we greatly appreciate not only the funding, but their collaboration, and several of the studies I showed you have CDC either primary authors or co-authors. Other ancillary studies have been funded by NIAMS, and the Arthritis Foundation recently funded some work on the microbiome that Dr. Loser is doing. I mentioned my Rheumatology Research Foundation work on ultrasound. They also funded a career development award that really got me going early, which I appreciate very much. And we've had many other funding sources over the years, including the Institute on Aging, mental health. We had a couple of waves of data collection that were focused really just on psychosocial and mental health measures, NIHS for some of the environmental exposures, the CORI for some related interventional kinds of things. GlaxoSmithKline actually funded some of the genetic work and some of the other cohorts I mentioned. And then obviously UNC and Thurston have been extremely helpful to keep things going and keep the infrastructure together. And this is a summary of all the references that were on the prior slide. If anyone wants to delve into this, this is obviously not the full list, but this is everything that I talked about in this particular talk. So you can feel free to look into things further. Oh, I guess I'll go back to that. So I think that's what I have, and I have some time for questions.
Hey, thank you, Amanda, for that presentation. Quick reminder to everyone to type in your questions in the chat box. And we'll also be launching a poll about today's presentation at the conclusion of the Q&A. I'd like to kick things off with a question. I mean, clearly through this presentation, you just tapped the surface of some of the many findings and areas of research, which is really exciting to have this type of cohort. But what are, I guess, some things that you are maybe starting to look into now, or maybe thinking about looking into in the near future, kind of generally speaking?
Absolutely. So, the epidemiology of OA is changing, as I mentioned, and we really want to be able to keep up with that. So certainly enrolling younger individuals and including Hispanics is a big focus of what we're doing now on kind of the epi side. I've been very interested in trying to keep ultrasound going and getting that in the new cohort, because that would be information that's really not out there at all, what ultrasound features might be like in a cohort like that. We have been interested in other comorbid conditions, again, that being just kind of an area that the medical field is moving towards, so how osteoarthritis and other musculoskeletal issues might impact cardiovascular disease and diabetes, and we have a collaborator who's interested in COPD, sort of expanding into some of these other disease areas and looking at other features. So a lot of work is focused on pain and structure, but there's also sleep and fatigue and a lot of other factors that really impact the patient's quality of life. And so looking into some more of those as well.
Yeah, I mean, OA seems to be very common with a lot of the conditions and disease status, like you just said, of sleep and all those other quality of life factors. OA is everywhere and a part of everything. So it's nice to see the research coming to bring things together to really show that connection through research, not just colloquially. Let's see, another question. Oh yeah, this actually, I have a similar question to what Katie's asking. Could you tell us about some of the physical activity related studies that have been done? I know here at the Alliance, we focus a lot on physical activity, weight management, injury prevention, all that. So I'd be interested to see what part of your studies have touched on that aspect.
Yeah, so a lot of what we've had to date has been self-reported physical activity, which we all know to be not overly reliable.
Mm-hmm.
And part of that was just logistics and being able to get it. But we actually now have a collaboration. We're able to get some accelerometers on people and get a more objective assessment of physical activity. And that's something we're really trying to carry forward into the full new cohort, because we think that objective assessment is really going to be helpful in addition to the self-reported measures. So I think that's an area that we're very interested in expanding our ability to provide some data about.
Great. Yeah, that's a great point about the self-reported, and using accelerometers should really help that.
Yeah.
Yeah. Great. Let's see if we have questions. And I just posted a link to the chat. We'll also post on the website, just a link to kind of the About Us page for the study from the UNC Thurston Arthritis Research Center website, if you would like some more information. And I believe it also links to kind of a PubMed list of a lot of the studies that have come out of this. And it looks like we just about hit our 30 minutes. And we will launch the poll now, so please answer that before you sign off. You can only answer while you are in the meeting. And next month, we will be having a presentation from Dr. Camille Barber, who will present on knee osteoarthritis and the risk of dynamically treated injurious falls among older adults. And that will be on June 19th. So please register and add that to your calendar as well. And thank you again, Amanda, for this presentation.
Thank you.